The topic this week is policeman's heel, more accurately known as plantar calcaneal bursitis, although if you look on a Google search, you'll find that plantar fasciitis and plantar calcaneal bursitis or policeman's heel are used interchangeably, and this is actually incorrect. Your go-to reference for heel pain is the American College of Foot and Ankle Surgeons Clinical Practice Guideline on the diagnosis and treatment of heel pain, first written in 2001 and then updated in 2010 and 2018 by Thomas et al. Really excellent reference. The plantar heel pad is a specialised organisation of tissue lying on the plantar aspect of the calcaneus bone. It diminishes with age, and we have cylinders of fat separated by small septa to form an integral network arranged in a very precise fashion, and it acts as a shock absorber, and it's a somewhat complex structure and anatomically very interesting indeed. And here's a small cross section. It really gives the foot a real degree of bounce on heel strike. Plantar calcaneal bursitis then is the development and inflammation of an adventitious bursa that forms subcalc bone and can cause severe burning, aching and throbbing pain, particularly those patients that have increased activity or increased weight gain, a relatively thin heel pad, and that will cause direct pain on compression right at the central, more proximal aspect of the heel. Here's one of the Podiatry Institute pictures just showing the location. It can be a little difficult to tell the location from a plantar fasciitis. Here's a clinical shot with initial treatment centred on reduction of compressive and shearing forces on that central plantar heel. Injection therapy is indicated for some cases, and we'll talk more about that in a second. Here's a sagittal slice on a T1 MRI, and you can see that there's been the development of a true adventitious bursal sac. You can see there's real fluid in that. You don't always see that, in fact quite rarely. I think you'll see that on a scan more often. Next up is an ultrasound scan. You'll see some inflammation and maybe some low signal on an ultrasound. And of course, even when you think you've got a classic plantar calcaneal bursitis, as I saw with this gentleman, sent off for a scan, and in fact what it came back as was a true plantar fasciitis. But you'll see from the scan that fascia is thickened and a little bit more proximal and subtuberosity of the calc. So even when you think you've got a true policeman's heel, sometimes it is a plantar fasciitis. Going back to the Thomas et al. Clinical Practice Guideline, this is one of the pictures that accompanies that article, and you'll see from the yellow, the red and the orange dot, these are all the different sites that you can see a true plantar fasciitis. The red dot, of course, is the most common site, but the yellow dot you can also see plantar fasciitis at this point here, as in the previous two MRIs. This, of course, is the same point where we see plantar calcaneal bursitis, and in practice it can be difficult to tell one from the other. In practice, I'm probably going to inject both, but I really would like a scan first so I know what I'm injecting and why. The next video it's an old video from my 2010 injection therapy book I did with Stuart Metcalf, and it just shows you my technique for injecting the plantar calcaneal bursitis. And if you look very closely, you'll just see a slight bald spot developing at the back of my head. So for plantar calcaneal bursitis, or true policeman's heel, the pain is very much central calc, which is different from the location of the plantar fasciitis pain, which is more anterior and medial. Steroid therapy can be used for these. The injection, having marked up the skin and prepared with iodine, is to go directly over and inject deep, again looking for a hot spot, looking for the point of maximum tenderness. At the point of maximum tenderness, aspirate and inject.